I'm Dr. Bev Gray, and I'm here with Dr. Jonas Swartz, and this is Outlawed.
We have an exciting interview today. We are talking with Isaac Maddow-Zimet, who runs the monthly abortion provision study for the Guttmacher Institute.
And why is this a big deal? This is a big deal.
It is a big deal. They have just released their counts for abortion in 2025. And so each year they release annual numbers on the number of abortions that occur in the United States.
It reports numbers of abortions by state and also number of travelers. And by looking at the data, we can see trends of what's happening in the U.S. and particularly what's happening since the Dobbs decision and how that is influencing where people can get care. Is care being impacted overall? Which states are seeing more patients? It's really interesting data for us.
It is. And I think it's been really validating for both of us also. Two of the states that are featured in the report this year are North Carolina and Virginia, states that get a lot of travelers.
And we both provide care there. And we have seen the people that correspond to these numbers, that correspond to the increases both in North Carolina and to people who are having to travel even further to Virginia. And we talked to Isaac about that in detail.
So we've both been traveling for, is it 3 years?
Yeah, I guess so.
What are some of the stories that stand out to you?
I mean, I think every time I drive into the parking lot, I sort of look at different license plates to see where they're from. And, you know, we've cared for people from as far away as Texas, Alabama, frequently from Florida. So Florida's laws changed a little over a year ago, and now they have a very strict ban. And so many more patients are having to travel from Florida. And I frequently talk to people who have driven through the night from Florida all the way to Virginia. And then as soon as they have care, have to turn around and drive back home.
Yeah, I think what stands out for me is this contrast between patients who may come with their family, right? So they come with their partner and their kids, or sometimes like a father or a grandfather will drive them and, you know, may have to be doing the childcare for the kids while they're there. And I think how, you know, touching it is and heartwarming it is that people have this support during their care, that someone is there to stand by their side and have that support. And then I also think about the patients who I've seen who don't have that support and scrounge for a ride. And then I've had a couple patients whose ride has left them while they were getting care. And then, you know, we have to scramble to get them a ride. But just like what difference that is in your life to be able to rely on someone to take you for essential health care.
We see so much desperation in the stories of like all of the things that people have to go through to get there, whether it's finding money for travel, finding childcare, finding time off work, you know, navigating even where to go. I mean, you know, if I needed a knee surgery and I had to go to Virginia to get it, how would I start? Like, where would I go to figure out care? And so a lot of people have already made it through all those barriers, and they get there and finally have this like immense relief at being able to arrive.
But, gentle listener, don't let us convince you that we are interested in this human side only. We're both big nerds. And so this combines all of our, you know, the love of numbers, the love of maps, and so
love of travel.
Love of travel. And so that's why these numbers are exciting too.
We often look to the Guttmacher Institute for information around state policy, around data, and they're a reliable source. And so it's great to have this report that explains what we're seeing on the ground. And Isaac has a lot of fun facts to share with you about abortion numbers in the U.S. last year.
Yeah, let's hear from Isaac.
My name is Isaac Maddow-Zimet, and I'm a data scientist at the Guttmacher Institute. I think when I started at Guttmacher, I said I would be here until I wasn't learning anymore. And almost 16 years later, I'm still here. For almost all of my career at Guttmacher, I've focused on abortion measurement. At first, that was both in the US and globally, in settings where abortion was illegal. And then for the last decade or so, it's been just focused on the US. Guttmacher is a research and policy organization that focuses on sexual and reproductive health and rights in the US and globally. It has been around for a long time. It was founded actually in 1968, so pre-Roe versus Wade. And it does research and policy work. That can mean a lot of different things. Most relevantly, Guttmacher has been measuring the incidence of abortion in the United States for almost half a century.
You're about to release a new report, and I'm curious, what are some of the headlines?
Yeah. So the data we're releasing are calendar year estimates for 2025 of the number of clinician-provided abortions occurring in the U.S. and the incidence of travel for abortion care across state lines. One big difference from prior data releases we've done is that our estimates are now including abortions provided by a telehealth to states with total bans. So abortions provided by clinicians in a state like New York or Massachusetts, which both have shield laws protecting telehealth, and then prescribed remotely to someone living in a place like Texas or Alabama. So one of the big things that we're finding is a continued decline in the number of people traveling across state lines for care, even though, of course, many, many people are still traveling for care. So, in 2023, the first year after Dobbs that we had comprehensive data on travel, almost 170,000 people traveled across state lines to obtain abortions. That declined to about 154,000 in 2024. And then what we're seeing now is a continued decline to 142,000 in 2025. And that recent decline was essentially entirely driven by a decline in the number of residents of states with total bans traveling out of state for care. So in 2024, about 74,000 residents of states with total bans traveled to states where abortion provision remained protected. And in 2025, that dropped to 62,000.
And yet, the number of abortions overall is pretty stable in 2025 as compared to 2023 and 2024. Is that right?
Yeah, so that's definitely true when we're comparing 2024 and 2025. So in 2025, there were about 1,126,000 abortions, clinician-provided abortions in the U.S. That's approximately the same number that were provided in 2024. But there is a shift in where those are happening.
Were there surprising trends or surprising data points that gotcha?
I mean, I think I'm surprised that so many people are still traveling for care. I talked about the fact that travel has been declining, that there's been this decline, and it's still so many people who are traveling, both just in raw numbers and in a historical context. Just looking at people traveling from states with total bans, about 62,000 people were traveled in 2025 to get care in more protective states. That's still more than double the number of people who traveled pre-Dobbs. That's not including folks traveling from places with 6 or 12-week bans, which is another 47,000 people in 2025. And it's not just that those numbers have gone up, but also that the distances have gone up so much as well. It used to be that if somebody was trying to access abortion care in Louisiana and they weren't able to access it in Louisiana, maybe they were traveling to Texas. Now they need to travel across multiple state lines to access that same care if they want in-person care. I always get stunned by the magnitude of it and how much that really impacts people's lives. It's a hard number to wrap your head around, honestly. If it's going down, that's a good thing if it means that people are accessing care in other ways that are less of a burden. And there will always be, as long as abortion is restricted in many states, a need for many people to travel. Later gestations, people sometimes have a preference for procedural care or in-person care. It's important to preserve the options that people have for the care that they want. And it's a tragedy. Abortion is an extremely common reproductive health experience. People should be able to access it within their community in the setting that they choose, using the method they choose. That they aren't able to do that is a grave injustice.
Doing a study like this requires a huge amount of person power and a lot of different inputs. Can you talk about where those come from and sort of who works on it?
Yeah, absolutely. So I think that it's helpful to zoom out a little bit to talk about kind of what motivated the way we designed this work. Counting abortions was never easy in the US, even pre-Dobbs. And then post-Dobbs, it got a lot harder. And that was something we were grappling with a lot as we were designing this work. And it got harder for a couple of reasons. One of them was that folks' needs for data changed. In the past, when we released data from these abortion provider censuses, they usually were about a couple years lag. So we needed to produce the data much faster. And then we also needed data at much smaller timescales. Before, we'd always produce calendar year estimates, but abortion policy was changing month to month, if not week to week, especially in the period right after Dobbs. And we needed to be able to capture the impact of those policies. And then that was all in the broader context of providers being really overburdened. It always had been a big ask for providers. And then suddenly providers were having to deal with legal complications in their state, an increased caseload, and a lot of asks from other researchers, from journalists about what they were experiencing in real time. And it didn't feel sustainable to go to those providers and ask for data every month. So that was what we were thinking about as we were designing the work. And then, of course, we were building on work that WeCount had done, another data collection effort from the Society of Family Planning, who had started collecting monthly data from providers a few months prior to the Dobbs decision. The big advantage we had was that because we had been doing this work for so long, we had a lot of prior data on abortion providing facilities in the US, on their caseloads, how they change over time. So a lot of what we were thinking about was how we could leverage all the data that we had from this long history, decades-long history of abortion measurement to produce high-quality estimates while ideally reducing the burden of data collection on facilities. Really, its goal is to produce publicly available estimates of abortion provision, travel across state lines, and other key indicators over time. And we do that by drawing monthly samples of providers. And we ask them just 4 questions. We ask them the number of abortions they provided by month. We ask them what state those folks are coming from. We ask them gestational duration. And then we ask one other rotating policy relevant question, which just lets us be able to be a little bit more flexible, to be able to collect data on things that we don't know if they'll be relevant in the future. One of the first rotating questions that we asked was actually right before we thought there might be a nationwide injunction against the use of mifepristone in early 2023. And so we asked people about what other abortion regimens they were using, whether they were using misoprostol only, whether they were using methotrexate, so that we could use it as a baseline if mifepristone was later restricted, to be able to talk about what the impacts on care had been and how providers were responding. And then sometimes we ask open-ended questions just about what providers are experiencing, what their challenges have been, what specific challenges are in serving patients traveling from out of state. And those aren't things that we publish. Those are usually just things that inform the kinds of questions we're asking, the way that we're framing our results, and often help us develop what other questions we might ask. Our primary filter for those questions is it has to be something that's easy for the facility to answer. So we collect those data directly from providers, and then we combine it with the data that we have from, again, the many years of doing this work on facility caseloads in a Bayesian model to produce iteratively updated estimates that we release monthly.
So say what a Bayesian model is. I mean,
absolutely.
It's statistics to guess. Is that right?
Yeah, I mean, I would say to make informed estimates. I think that, it's always been the case that estimation has played a role in pretty much every abortion measurement effort that has occurred in the U.S. That was true of prior censuses as well. It's always been the case that some providers don't respond, aren't willing to give data. And so we rely on auxiliary sources or similar caseloads of other facilities in the state to be able to estimate those. This is just one way of doing that. I say Bayesian, it always sounds very fancy, but really it's just a way of taking the data we know about what a facility's caseload could be and putting it together in a principled way where we can produce estimates that foreground the uncertainty that we have.
And one of the interesting things about the data is that, and tell me if I'm wrong, but I believe that you're collecting that data from clinics that are in states without bans, right? And they're reporting, those clinicians are reporting that they're caring for patients who are traveling to them or seeing them via telehealth. But that's how you know that folks in Texas, for example, are getting abortions, not by speaking with people in Texas. Is that right?
That's exactly right. And that's one of the big challenges of abortion research more generally, which is that we can't really ask about it in surveys. I mean, we do. and people certainly do in general, but people typically don't report their abortion experiences in surveys because abortion is so stigmatized in the US. So it makes it a real challenge to measure. So historically, the data we've collected and that others have collected has always been from providers themselves. So we go to providers and we ask, how many abortions did you provide, in this case, by month? And we ask other things about the patients that they provide care for. So most relevantly here, the state of residence of those patients. So that's how we can see how many people, for example, from Texas are traveling to a place like Illinois.
I understand the data landscape, but given the complexity of data collection, I think it is surprising that the government doesn't do it, right? So why doesn't the government collect this data? Or why does Guttmacher have to do it?
Yeah, that's a great question. So let me start out with the government. So a lot of state health departments do collect abortion data, and it is unusual the way that data is collected. Abortion is one of the few things that in many states is legally mandated to be reported to a state health department. That's certainly true in North Carolina. It's true in a lot of other states as well. It's unusual to be in that category. The other things that are usually in that category are things like births and deaths, which are kind of core vital statistics, and also things like infectious diseases, where there's a compelling public health reason to be able to track and stop the spread of that disease. Abortion isn't a disease. It's not something that's infectious. It's also not something that's necessarily in the same category as births and deaths. And the reasons that it's that reporting is mandated are complicated, and they haven't always had the greatest history of being used for the best purposes. A lot of states have reporting requirements that aren't really linked to public health. They often ask things that are pretty intrusive, that don't really serve a public health purpose. Even something like the reason somebody is having an abortion is not something we really would ask about for any other kinds of medical care. Those state health department statistics, and not all states collect them, but those state health department statistics are compiled by the CDC into a national report that has been coming out for pretty much as long as Guttmacher has been producing data. The first ones were from the early 70s. Those data have always been considered fairly incomplete, especially over the past couple of decades. They're missing some major states, California being one of them. Individual state health department reports often are missing substantial numbers of abortions, so they're kind of a variable quality.
I also have this worry, and I don't even want to say it out loud, but that legislators would use the data to find ways to restrict care.
Yeah, I mean, that's something that always is a huge risk. I mean, once we put out estimates, we have no control over how they're used. And that's something that we talk about and think about a lot, and makes us very careful about what we ask about, and what we think is worth asking about and is critical for the field and for providers to know, versus things that we just might find interesting as researchers. There's a lot that I find interesting as a researcher that isn't actually relevant for providing better care or informing policy. And it still remains the case that estimates and data can always be weaponized. And it's one of those things that, I think we just have to come to terms with, that part of making estimates public is they can be used for other purposes as well.
We want to talk for a minute just about North Carolina numbers, because I think North Carolina is an interesting example of a state where, we have our own gestational duration limit here of 12 weeks with a variety of exceptions. Yet we've seen an increase in our number of travelers over these last 3 years. And we've definitely felt that increase in volume. And we've changed our clinic setup to be able to accommodate some of those patients. But I'm curious if you have any other thoughts about what you see in the numbers of North Carolina.
Yeah, I mean, and you're right, there has been a really big increase in the number of people traveling to North Carolina, both compared to pre-Dobbs and also more recently. And, most notably, I'd say after Florida's 6-week ban went into effect in 2024, North Carolina saw a surge of folks traveling from Florida and surrounding states. Florida was a place that already had some restrictions on abortion, and it was one of the only places in the Southeast where people could receive in-person care at a clinic in the vast majority of 2023 and the beginning of 2024. And so when Florida's 6-week ban went into effect, that became an enormous problem for Florida residents if they wanted or needed in-person care. Just to put some specific numbers on it, we haven't actually released specific state flows for 2025. So, how many Florida residents are traveling to North Carolina. But even just looking at the 2024 numbers, just to kind of compare here, in 2023, before Florida's 6-week ban, about 200 Floridians traveled to North Carolina. So some, but not a ton. In 2024, which again is the 6-week ban was only in effect for half of the year, 8 months of the year. That number jumped to 1,380. So it increased by more than 6 times. A lot of Floridians were also traveling much farther. We saw increases in places as far away as New York, certainly increases in Virginia as well. But it kind of shows the lesson we've been learning throughout doing this work, which is that what happens in one state has ripple effects in many other states across the country.
Every time I'm in Virginia, I write down the states where people came from. And a recent trip, it was Virginia, Georgia, Texas, South Carolina, Florida, North Carolina, West Virginia, Louisiana, and Tennessee in, a 2-day span. So, people are coming from incredible distances, some flying, many driving. Many Southerners drive. A lot have never flown in a plane before, so they hop in the car for 12 hours, ride overnight, get their care, and then drive back. It's incredible what people are going through when they're traveling.
Yeah, absolutely. None of that feels like a surprise to me, and it still shocks me every time.
If you had asked me how I was going to meet people from states across the United States, this is not how I thought I would.
How did you think you were going to meet other people?
I don't know. I guess I don't have an alternative, but you would think you would meet them through your own travels or, when you were in college or even when you teach at Duke, right? Like you meet people, but I'd say I meet the most people from other states providing abortion care.
Yeah.
How does the data inform care?
I think that's a great question. I think that it's really important to know what's going on in the abortion provision landscape so you're not having discussions about how to improve care for patients that's detached from the reality of what people are experiencing. I don't think that people necessarily expected abortion numbers to be higher post-Dobbs. If we didn't have these numbers, then I think we'd be having a much different conversation about how to best meet people's needs. I think that, when it comes to travel data, especially, we see the importance of it in talking about really the broader infrastructure of support that people use and depend on to make that travel happen. Even in 2025, which is lower than the 2023 number, 142,000 people traveling is an enormous amount of people traveling. It has required an enormous amount of support, and that support in general has been dependent on an initial surge of donations and interest post-Dobbs that has largely fallen off or has not necessarily been sustained in the long term. It's something that remains a really big challenge in terms of that sustainability, and being able to talk about what those numbers look like and how they're changing lets us help make the case for why those broader networks need sustained support. It also lets us talk about the way in which specific states play really critical roles. We talked about North Carolina and Virginia. Illinois is another one I would highlight because so many people travel from all over to Illinois. Illinois is treating about a quarter of all the people who are traveling for care nationwide, both because of funding support available there, because of its geographic location, and because of a broad network of clinics that have done a lot to try to make sure that they can serve patients traveling from out of state. The other thing I would add is that I think we've learned a lot of lessons about what gaps in provision were even pre-Dobbs by looking at what the numbers are now. Part of the story about why abortion numbers have increased post-Dobbs is certainly the ways in which people have really worked hard to increase access for people living in states with restrictions. But the majority of the increase has been driven by residents of states with protective policies in place. That speaks to, frankly, a lot of unmet need potentially and a lot of barriers to care pre-Dobbs. And the one I'd call it specifically is cost. Abortion is not something that has been historically pretty easy to access. The average cost of an abortion even in the first trimester, so the cheapest, was about $550 pre-Dobbs. That's out of reach for a lot of people. And often, depending on what state you live in, insurance won't cover that. And so a lot of the funding support that has come into play post-Dobbs, as well as the availability of things like telehealth, which are often lower cost, has potentially reduced a lot of barriers to access that we knew were there, but I think that didn't necessarily understand the scope and scale of.
When you were starting off, one thing that you said that I think is really important to point out is the thing that you're counting are clinician-provided abortions. And in the report, you do talk about some of the areas where you may be missing.
Yeah, absolutely. And it's a great question. So we're missing a few things. The main thing that we're missing is we're providing any abortions that are provided by people who aren't clinicians. That would be abortions, for example, provided through community health networks, through pharmacies overseas, where somebody might go to a website and order pills from a pharmacy located outside the U.S., or other kinds of self-managed care. We're also excluding the very small number of abortions that are occurring under exceptions in these states with total bans. That doesn't have a big impact on our estimates. But in terms of other provision, so through things like community health networks, that's something that we know has always happened. That was happening pre-Dobbs as well. And it's something that we know increased a lot after Dobbs as people were looking for other ways to get care. And it means that our numbers are almost certainly an underestimate.
You mentioned exceptions, like the state-based exceptions. Can you explain those sort of in lay terms, what that means?
Yeah, absolutely. So a lot of states with total bans, if not all, have some exceptions written into their laws. So we say that they have total abortion bans, but there are small exceptions for example, the life of the mother, or in cases of rape, for example, sometimes in cases of fetal malformation. It differs by state. Those abortions do happen. In practice, it can be extremely difficult to access care under those exceptions. It can be difficult for providers to actually provide them under those exceptions. And it also can be difficult for patients to know that they're available or meet the requirements. For cases of rape, for example, people often need a police report, or even if they don't, still need to be able to be willing to disclose something that's intensely personal to be able to access abortion care. Some people end up traveling instead, or not accessing the abortion that they need. These exceptions exist. I will say that we have seen many examples of providers, especially in states with total bans or restrictions, working hard to try to provide as many abortions under those exceptions as they possibly can, under the limits of the law. And in practice, it's a small number, and it's something that remains incredibly hard to access. Measuring unmet need for abortion and who is not able to obtain an abortion, who wants one, is one of the biggest challenges that we have. And I don't think anybody has ever come up with a good way of really getting an accurate measure of it. And we ask about the obstacles they experienced on the way to getting to that clinic. And we still know that those are the people who made it. Mm-hmm. I don't think we've really ever had a good sense of who are the folks who don't and how that's changed.
I feel like the waiting time for patients, both in North Carolina and in the Virginia clinics, has increased. And so potentially asking, when is your next available appointment? Because I think that those waiting times can also push people further. They have to, if they're in Florida and they're 8 weeks but can't get to North Carolina until after their 12 weeks, then they have to go to Virginia and then, potentially wait there. And so, that's another, I think on the ground, something that we're seeing is that people are waiting longer to get in for appointments.
You mentioned briefly that states have responded differently, those travel states. And you touched on the infrastructure changes in Illinois specifically. Can you speak to, states have taken different approaches to that, but those big travel states, what are some of the approaches that those states have taken, and what can you tell from the data what works?
Yeah, that last part is the hardest, I would say. But certainly folks have taken a lot of different angles. And I will say, I'm not a policy expert. Take things that I say with a grain of salt here. But there's been different tacks. Part of it has to do with the different roles that different states play. So Illinois serves a lot of patients from all over the country, partly because of its location. That was true even pre-Dobbs, that a lot of people were traveling to Illinois from a lot of the Midwest. People are now traveling much farther for care and in much greater numbers. But certainly it's always played a kind of central role. Some of the things we've seen in a place like Illinois are new clinics opening, including clinics along the border or very close to where people are traveling that are really focused on providing care to people traveling from out of state. Illinois recently also just announced a partnership with a fund. They created something called, very recently, actually, in 2026, they created the Prairie State Access Fund, which is a public-private partnership to fund access for both residents of Illinois and more broadly. So that's an example of a state really leaning into kind of directly funding care. There are other states that look very different. So like New Mexico is another state that has had an enormous influx of patients traveling from out of state. The majority of people having abortions in New Mexico are traveling from out of state. And while in Illinois, those folks are traveling from all over, almost all the people traveling to New Mexico are Texas residents. And then in a bunch of states, we've seen just kind of broader protections being passed around providers providing care to people traveling from out of state and also folks helping them get that care. And then there's been a lot of innovations at the provider level to just try to figure out how to change workflows and provide or put folks in contact with wraparound services to be able to address the many complex needs of people who are traveling.
Yeah, you really touch on the fact that, right, we're not equipped as providers, clinics were not equipped to do that. And it took a while for us to get ready to be able to say, all right, well, this is the organization you need to call. You may be able to get funding from them, or we can connect you. And to know what that landscape was took a while. The other thing, like in North Carolina, I think, is that building out the clinic schedule so that there were 60 slots so that those, counseling slots didn't push out the patients who were there for care that day.
There was a lot of bad things that came out of Dobbs. And there's something that I continue to find really inspiring, which is the way in which many, many people have come together to try to sustain access to care. That's providers, that's abortion funds and practical support organizations, that's folks providing telehealth under SHIELD laws, and have really tried to integrate and support each other in providing care during a really strained time. It's also something I feel a lot of gratitude even for the provision study work. I find it magical that providers give us data when they're doing so much else. I see data as it comes in, and every time it's still exciting, every individual data point. And I feel a lot of gratitude because the work wouldn't be possible without folks giving us data. And it is not central to their core care. And I feel a tremendous amount of responsibility to make sure that those data are useful in actually making change or informing the way that people provide clinical care or design policies.
All opinions expressed on this podcast are our own.
Philanthropy keeps this podcast ad-free, and to donate, you can find a link in the show notes.
This podcast is produced by us, Dr. Beverly Gray and Dr. Jonas Swartz, as well as Stevie Manning.
Thanks to Nick Thorburn, Patrick Ford, and Maker for our score. And extra special thanks to everyone who lent their knowledge and voices to the show today, especially the folks from Guttmacher. We heart Guttmacher.
We do.